This 69 years old patient, mild ischemia, history risk factor for hypertension, dyslipidemia, hypothyroidism. He had an inferior ST myocardial infarction in June 2017 with a primary PCI in another center with a good clinical evolution. Then the patient continued asymptomatic with a negative stress test at the follow-up. The ECG showed us a sinus rhythm with a myocardial necrosis in inferior wall. The blood test is normal. The echocardial Doppler has preserved a low ejection fraction of left ventricles, 55%. And the echo stress showed us that the patient had angina and anterior ischemia with hypokinesia in this region. This is the angiography showing us a mild diffuse right coronary artery with a stent in the proximal and middle section of this artery without restenosis. This is the left coronary artery with a mild stenosis in the circumflex artery and a severe stenosis, a moderate stenosis at the proximal LAD and the severe stenosis at the middle segment with a first diagonal compromise. Critical stenosis at the middle segment with first diagonal compromise. So in summary, this is a 69 years old patient with a previous ST inferior myocardial infarction. Now the patient is asymptomatic with a severe LAD diagonal bifurcation stenosis with a Medina classification 011. The heart team's suggestions was LAD and diagonal PCI. So the strategy will be a radial access with a double kissing, double crushing technique guided by intravascular ultrasound.
Go back to the lab. So in summary, it's a young patient that did well after this primary PCI until this new positive stress echo, Gustavo, and that's why this patient underwent coronary angiography, which is not that usual to indicate an angiography on stable patients here in the clinical practice of the hospital. Is that correct? Okay, perfect. And then you might
Yes.
can describe what you have already done here.
Well, the radial access was performed by a 7 sheet. Then we choose an XB guidance catheter 7 French in order to perform the bifurcation we described before. We reach a severe tortuosity at the subclavian and brachiocephalic arteries. We could reach the left vein without any problem. We, after punching the radial artery, we put a 5 introducer sheet, and then we change it for a 7-1. You are right.
Give me the torque. So the idea here is to put 2 wires, 2 regular wires, to predilate with a 2.0 balloon, and then probably do IVUS if we can. Yes. Okay. We need a small vent because there is a quite straight vessel with a lot of branches before the lesion.
So in this case, you will predilate the LAD in order to perform the ultravascular ultrasound.
Yeah,
study.
I think if we can do this, it's gonna be better because we can decide which stent. Give me the torque. I mean, more rational decision using the IVUS.
Okay.
Probably I did now. Small vent. Let's test. Now we are better. Give me the 2.0 balloon.
Okay.
2020. Let's go. He showed a 2-stent strategy using DK crash is better than only 1 stent for this side branch with the significant lesion and long lesions. So here, now we have to predilate the diagonal very gently to prevent any kind of dissection. So the idea of 2-stent in this case is to use DK crash.
In the DK crash trial, show that this technique is better than culotte stenting.
Yeah.
With less TLR and MACE.
Okay, let's go there. Okay, perfect. Display. Okay, that's it. Gustavo and I go with the IBUS. One can prepare a 3.0 short balloon. No, can be a compliant balloon. It's okay. Preparar el balón de 3020. Let's go with the IBUS. Which IBUS have you prepared, Gustavo?
This is the Eagle from Vulcano.
The imaging of the IBUS. Okay. Let's go from there. May I help you? Yeah, let's go. Pull back.
Image.
The IBUS on the screen. The configuration perfect. We see a small artery there.
So we are performing the pullback from the distal segment LAD. We have a severe calcification.
I would say
Circumflex.
fibrotic plaque there, no? And there is the
Yes.
calcium,
Yeah.
180 degrees in the plaque. The vessel there is approximately 3. And there is a very tight stenosis where we have problem to cross with the IBUS after the bifurcation. There is the ostium of the diagonal. There is a proximal segment of the LAD. You see the second wire.
You're right.
So calcification, but the area is okay except there. There is the ostium. The left main is very short. My plan would be to do the bifurcation first, and then we can fix the proximal segment with a short stent. Give me the 2.5 balloon. I will pre-dilate a little bit more for not having any kind of problem because it's very calcified. Give me the 2.5. We'll pre-dilate post diagonal and the ostium of the diagonal. I will fix first the diagonal. Okay. The bifurcation, and then I will deal with the proximal part of the LAD.
At the IBUS, we saw a surface severe calcification and 360 area.
Let's go to pre-dilate there. Deflate. Let's go once again. Perfect. Okay. Deflate. There, 1, 2, 3, 4. Okay. Okay. Now we are going to pre-dilate again the ostium of the diagonal. Stay connected with the deflator. This is the diagonal, which is the wire which has a vent. And prepare a stent at 2.5 by 24. Okay, ultra thin strat biodegradable polymer stent. Let's go, Gustavo. 1, 2, 3, 4, 5, 7, 8. Let's go with the stent.
So you're going to stent first the first diagonal?
Yes, and we put a 3.0 balloon for crashing from the LAD.
Okay.
Give me the 3.0 balloon. We need 2 deflators. And now the balloon. And now test. Okay. Inflate the stent. 1, 2, 3, 4, 18.
18.
Tape, guardar. Desinflar. Deflate.
Okay.
Okay, diagonal, I think it's perfect.
Yeah.
Now we are going to pull the balloon, and first we have to pull the wire.
Yeah.
We have the wire. Let's pull the wire. Crash it. Yeah. 1, 14. Perfect. Okay. And now I will advance the balloon so I can reposition in the guide. The balloon is very easy to cross. So let's pull the balloon out so we don't destroy the wire.
Okay.
And give me the wire. Normally, I would rather like to go with the regular ones. We have to go to the LAD first. I try to cross distal. Give me the 2.0 balloon, probably a new one. We'll see now when we have to reopen the cell. Give me a 2.5 by 30. We will go first septal branch or before until the second big distal branch with the 2.5. And then we will finish with the bifurcation, and then we will put the proximal stent. Pull it. Let's go out and let's go for a kissing balloon. Give me the 2.5 and the 3.0, and then we will go with the stent. 2.5. So probably when we open the cell. Okay. Well, inflalo. 1, 2, 3, 4, 5, 6.
LAD.
Sí, 7, 8, 9, 10, 10. There is some resistance here to advance also the balloon. Infla primero este, the LAD. Okay, let's try again. One is going to hold the 2.5 from the diagonal. Now it's going to hold the 3.0 from the LED. And then we will try with the stent again. So now we have a perfect advancement of the stent. You can see that the perfect test. I think the position is perfect. We have to retrieve the wire. Okay, inflate. 14.
14.
16.
Yes.
Deflate. Let me try if I can recross now. Doing this. We have a very unstable position with the guiding. Have destroyed the wire again. Take this balloon out. Let's pull the wire. Let's reshape if we are lucky enough. If not, we will change it. Let's try once. Doing always the best for patients. I think the wire is not in the proper shape for crossing the diagonal. Let me see if I am lucky enough. No. Give me another wire. The fielder. Prepárate un balón 3-5 corto. So if I can cross, I will do pot. Was almost there.
Yeah.
I need to be patient. Patient is too big. That's why I don't have a very nice imaging. There is when
you're right.
And when the wire goes, you are happy.
You told us.
Now you might have the new 2.0 balloon that you have behind.
Yeah.
I will reshape the wire again with only one stent. Dame 1.5 balón. So here I cannot cross. I had to insist with the smaller balloon and then to recross in a different place if it is not possible. So let's try again with a smaller balloon. Now I think we are in. Inflate now. 1, 2, 3, 4, 5, 6, 7, 8, 10, 12.
Yes.
Deflate. Okay, inflate and deflate again. High pressure 20.
Yes.
Okay, deflate. Give me the 2.0 again. Okay. It's time to pray that we cross. So you can inflate, but give me that the 3.0 balloon again. 1, 2, 3, 4, 5, 6, 7, 8. Deflate. Okay. Okay, we have problem to cross. Maybe we can advance the balloon again. Let's try again. Probably we have
Cross the wires.
Cross the wires or something like this. Inflate 1, 2, 3. Yeah.
This one.
Yeah. Deflate. If not, we are crossing with an old 2.5.
Perhaps wires are twisted.
Maybe, but I don't want to pull it.
Okay.
The bifurcation is okay. Both vessels are okay. So we have just a matter of time preparing this bifurcation. Let's go that way. 1, 2, 3, 4, 5, 6, 7, 8, 12, 14.
14.
Deflate. 14. Dame el 3-0. Okay.
Yeah.
Deflate. With a 2. Okay. 2.5 is okay. Give me the 3.0. If not, we are going to use a new one.
Okay.
Should go.
Tiene que tomar un 30N.
10 minutes to go. So now it's okay. Let's do
4.
deflate both. I see if I can go a little bit further. Let me see. Stay quiet.
Okay.
A deep angulation down. I am
So
pushing the wire a little bit.
I think that you you took
Now we are
right,
better. 1, 2, 3, 4, 5,
you took
8.
the right decision to perform it with 2 stents
Yeah,
because it will be very difficult to recruit with a provisional balloon.
absolutely. Okay, done. Okay, let's put everything out. And let's do ancho. And
need
let's do
nitro?
IBUS. And let's see if we can deploy the proximal stent. Let's take out this.
Mhm.
Well, the guiding, as I already mentioned, is not in a good position. The table is not that comfortable for Gustavo, but the
Okay.
bifurcation is perfect now.
Yeah, this is the IBUS.
Let's see. I will do the LAD at least, and then I will fix the proximal part of the LAD. And then probably out of camera, I can do IBUS with the diagonal just in case. ¿Tenés firme?
Mhm.
So we have resistance there. I don't know if I can advance the IBUS more. Because we have a lot of angle there. Once again.
Are you going to?
Móvemelo para acá adelante.
Okay.
Okay. Let's fix the proximal part of the LAD. We have done 3.0 there, 18 atmospheres. Probably we can post-dilate distally to the bifurcation after deploy the proximal stent. Anyway, it's difficult to cross with other tools. Let's go there. 1, 2, 3, 4, 5, 6, 7, 8.
Yeah.
Deflate. Something is wrong, still wrong there. 1, 2, 3, 4, 5, 4, 18.
18.
Okay, that's it. We touch the carina. So anyway, we will have to retouch after at the end of the procedure. Looks better, but there is a calcium protrusion there that probably is interfering with the crossing of the IBUS. Let's try once. We have chosen this IBUS and not the solid one because this one has a lower profile. But anyway, you observe that Gustavo is flashing. Okay, give me 1 minute if I can cross and show the
Yes.
and then I will say bye. For the bifurcation, you see a very good stent expansion. I will do it faster. Very good apposition. The diagonal, which is perfectly open. This is the stent in the LAD, is 3.5 or something like this. Now we are going to deploy a 3.5 stent before the bifurcation. Then we will do a final kissing and we are done. I will do the final angio. And I think for educational purpose, I think everything was completed. Perfect. Thank you so much.